conventional. You know, momentarily forget here that this tooth is an upper right tooth, and when I look at this, it looks like it's flipped around, and in fact the MB actually looks like the plate because it looks like it's by itself. Where the DB might be and where the Palatal is and where the MB is, maybe this is kind of a C-shaped tooth, but you know, I have a little feel around here, and I feel like when I look at these canal orifices, there isn't a slither of kind of canal or like an isthmus between. So I don't think this is a C-shaped tooth. And then obviously the nurse comes back. She shows me this comfort radiograph, and it looks absolutely fantastic. So hello, welcome to this week's Friday clinical case. This is another interesting case because this is of a canal orifice which isn't in the traditional location where a canal orifice would be. So it's sort of kind of disorientates me a little bit, and hopefully today you look at this case and it helps you find that elusive canal orifice that you don't find. We also find MB2, and on top of that we find that the MB2 has its own separate canal orifice, so it doesn't join into the MB1. So lots and lots of learning experiences today. But before I introduce you to the case, what I do say is that over 50% of the people who watch these videos are non-subscribers. So if you could just do one thing, it's quick, it's easy, and it's free, just to hit that subscribe button. We've also got a membership program. The membership program gives you early access to content. So we usually work about 3 or 4 weeks ahead with these videos. So if you like this video, you want to see early access, you can join the membership program with YouTube, and you can see them, the ones that are due to be dropped every Friday. And we've also got exclusive content. We've got a fantastic endodontic access video, and we've also got the part 2 to our newly qualified dentist lecture as well. So we'll get on with the case. This is a case of upper right 6, and we look at the X-ray here, and it looks very unusual, doesn't it? You know, we can see that the root form here is probably conical in shape, although it's not entirely sure what shape this is, because when we look at the upper right 7 next to it, we can see there are obviously 3 defined roots here. And also another issue with this case is that we can't see any obvious canal space. Maybe if we sort of squint our eyes, we can maybe see the palatal. But overall, this is an unusual case. And straight away in my mind, what I'm thinking is this tooth either supercalcified, or is it got an unusual root form? So it's something you just got to keep your eye on when you're accessing these teeth. It's also got decay in the tooth, and it's got a failing restoration. So in the very, very first instance, what we need to do is we need to remove this restoration and check its restorability. And we move over to the video here. We can see that in this case, because we need to check the restorability of this tooth, because we need to do a full filling before we do the root canal, I'm going to multi-isolate this tooth, because essentially I need to make sure I get the mesial and distal contact points. And then obviously we just got to check that the rubber dam clamp fits on here, and you can see that it actually does fit nicely. And then in this case, I put the rubber dam onto the clamp rather than putting the clamp on first and then putting the rubber dam over. And then when we assess the tooth, we can see that it's got this very large amalgam filling. You know, the restorability is not obvious in this case, but once we remove the restoration, I feel like the contact point between the rubber dam and the tooth isn't great, so I'm just going to floss that down, and then I'm going to pick up my slow handpiece, my rose head, just to remove the most of the decay. And in this case, I'm not worried about the pulp because I know the pulp's dead, so I'm just going to really give it a good clean out. And there's always a little bit of a worry here that you're removing too much tooth tissue, but when we can see here that the pulp chamber is now exposed, and that gives us a little bit of a orientation for us to know how much tooth tissue to remove and how to access this tooth properly. And what you'll notice is that once you remove all the decay, you'll have a little bit of undermined enamel. So you don't want sort of hanging over pieces of enamel, so you can use a fast hand piece edge just to remove it. And then I try to place a matrix band on this tooth, but the problem with this is the contact point between the two teeth is stopping us from doing this. So what I do is I try and place a bit of a wedge in there to try and open up the contact, but again, I try and place the matrix band on, and it doesn't allow me to push it down. So what I'm going to do is I'm going to just get a very, very finely tipped burr here just to remove the contact point. The problem with this is, of course, is it's really, really difficult not to damage the tooth next door to it. So you're just being really, really careful. I'm just very, very gently just opening up the contact. Also, I don't want to remove it too much because it's harder for me to place the contact back, especially with the matrix band. But once we remove the contact point, the matrix band on goes quite nicely. Of course, I've got the mesial distal aspect of this tooth, so there's a poor adaptation you can see here. So I'm just going to place some wedges just to make sure the matrix band is adapting nicely to the margins of the tooth, and also it's going to wedge it out slightly. So when you place the composite filling and you remove the wedges, the contact points between the filling and the teeth are all nicely. We're then going to do some selective etching here. I am just etching the enamel for now. And then what I do like to do is once I feel like I've etched the enamel, I do place the etch just on the dentin, just momentarily, not too long. And we can see here now that the cavity is ready to bond. I'm using eye bond in this case. I'm going to give it a really good massage into the cavity, and then we're going to use a bit of flow. I always like lose a bit of flow because I feel like it adapts to the cavity floor quite nicely. Just got to be careful you don't use too much of it because we're worried about C factor, of course. And then I'm going to start building up the wall. And maybe in this case, I used a little bit too much composite. Of course, we talk about this C factor issue, but I feel like that there's not many surfaces this bonds to, and also I can feel like I can cure all the way around this. And then another thing what you could be careful of is that when you place this composite, it doesn't go down the cavity where the pulp chamber is. I'm just going to use a DG16 endodontic probe just to remove some of the composite from this access cavity. It's not, you'd have to remove all of it because when you start to access this tooth, you'll be able to refine it, but sometimes it can be a bit difficult if you could block it completely. And now when we give it a bit of a polish up and we have a little look at the restoration replace, it looks all right. It doesn't look too bad. It's not perfect, but don't forget this tooth's going to have a crown on it eventually. This is essentially just to get the patient over the line till they do get a crown, and also it's going to create like a kind of a cup or a bathtub ready for us to put our irrigants in. Because if we were to use the irrigant and the filling wasn't in place, then it'd get everywhere and the patient might taste it in their mouth. So straight away when we look at this access cavity, it doesn't look conventional. I momentarily forget here that this tooth is an upper right tooth, and when I look at this, it looks like it's flipped around, and in fact the MB actually looks like the plate because it looks like it's by itself. And in fact I place my size 10 K file into the disto-buccal, and I just feel like I can't really get that far. And again, it looks like this is the Palatal, if you sort of know what I mean. So what I do need to do is, because the size 10K file isn't reaching down into this MB canal, I'm just going to step down into a size 8 D finder, and I have a little watch wind with this, but again I feel like it's getting a little bit of resistance, so it's not going too far. So what I do is I move the stopper to as farthest point we've reached, and I'm going to measure that, and then what I'm going to do is I'm going to use a succession of higher diameter files, not past this amount. So the furthest point we've reached is 18 millimeters. I'm going to get a size 15 glide path file, measure it to 17, and then give it a little bit of a shape out. And then don't forget to do our recapitulation. And then once we have recapitulated, I just can have a little look at this MB, and I just feel like it just looks like the MB orifice is just looking a little bit unusual. I think maybe the reason why the hand file isn't reaching all the way to the end on this is that because it's getting stuck at this orifice, because it's kind of like a little bit of an overhang here. So unusually in this case, I'm going to use an orifice opener. I'm worried about ledging this tooth, so I don't want to use a size 25 normal file just to open up the orifice. And we can see here that the orifice is looking pretty open here in the MB. And then, you know, I just thought to myself, well, maybe the palatal needs a little bit of an orifice opener as well. So I just get the orifice opener down there and give that a bit of a clean out. And then, you know, there's a bit of a... I can't quite work out where the DB is, because when we look at the MB, it looks like it's by itself, like it would be a palatal canal. And when I look at the palatal canal, there looks like there's like a little bit of a slither of maybe it's the pulp chamber, or it's sometimes the canal orifices can have look like they're a bit of a slither, and I can't actually see where the DB is in this case. I've got a suggestion. It is nearer to the palatal than it is the MB, which is really, really unusual. But what I'm going to use is a low energy ultrasonic just to remove some of the pulp chamber floor. Got to be careful you don't perforate the tooth, of course. And then once we've used the low energy ultrasonic, I'm just using the high energy just to give a bit of clean out. And just having a look around. I'm also looking for the MB2 in this case as well. And in this case, you know, I'm looking at this tooth and I think, you know, where the DB might be and where the palatal is and where the MB is. Maybe this is kind of a C-shaped tooth. But, you know, I have a little feel around here, and I feel like when I look at these canal orifices, there isn't a slither of kind of canal or like an isthmus between. So I don't think this is a C-shaped tooth. But we can see that there is a DB. I mean, granted, it is quite palatal to the MB, but it is the DB. And then when we get a size 8D finder, and then we kind of hook this up to our apex locator, I can see that we are starting to sort of negotiate down. So when we hook this up to the apex locator, you know, we're kind of close, not too close. And then we do a little bit of watch winding, and this is now reaching down. I'm not getting much resistance at all. We get our 0 reading. We then push the hand file through the 0 reading, so we go past 0, and then once we pass 0, we sort of back up the hand file, and once that reaches the 0 reading, while we back it up, that's our apex locator reading. We move the stopper, of course, and we measure it, and we can see that the DB canal is 19 millimeters. So because I'm struggling slightly, I can feel a little bit of resistance with the DB. I'm obviously going to use my glide path file at 0, but I'm going to use a size 20 high flex here. And this is a kind of a nice step up between the 15 to the 25, because it's quite a big step. But the DB, although we found it difficult to find, it was shaped quite easily. We're now going to get the working length in the palatal. Again, this hand file drops right down to length. It pushes all the way to 0 really, really, really easily. Again, it's the same protocol with the working length as with the DB, is that we're going to push the hand file through the apex, not too far, of course you don't want to damage the periapical tissues, and then as we back it up, that's our 0 reading. And in this case I'm using a size 10, mainly because a higher diameter file is going to give me a more accurate reading. You know, they say a 15 is the best, but I do find that an 8 gives you quite an accurate reading, and when we do the working length, it's found to be 21. And in this case, unlike the DB, because the hand file dropped to the palatal really, really nice and easy, I can go from a size 15 straight to a size 25. And of course this shapes it really, really nice and easy. And then don't forget, we've coronally shaped the MB, so as we get our working length in this, before it was struggling to get to length, but actually now I'm using a size 8, and this is now dropping down with no resistance. And you'll notice when you're using the watch winding motion, you can feel that it's going. Sometimes when it's not negotiating nicely, you feel like stop, or you get quite a significant amount of resistance. But of course, when we do our apex locator reading, we get really nicely to length. The MB is found to be 19 millimeters. And you know, despite initially having difficulty with the MB, I feel like the hand file in the second time I try to get to length goes to length quite nice and easy. So again, I'm gonna like the palatal, I'm gonna go from a size 15 straight up to a size 25. And of course, if I'm using a size 25 and it is getting a bit of resistance, I can always drop it down to a 20. So we found the palatal, we found the DB. You can see it's in an unusual position. Now I'll be looking for the MB2. And, when we look here, we can see there's a suggestion here of an MB2 orifice. And straight away, what I'm thinking to myself, does this MB2 join with the MB1? But I do have my doubts about this this DB, so I'm just going to have a very, very quick look with my low energy ultrasonics in the area where I would classically see a DB, because there might be a double palatal. It's unusual, but it's a possibility. So I have a little feel with the high energy ultrasonic in the area where I might see a DB orifice, but also at the same time I'm going to be looking for or opening up the MB2 orifice. Just got to be really, really careful again that you don't perforate this tooth. And when we have a little feel around here, of course, I like to use it without water. Got to be careful, of course, you don't cook the periodontal tissues. And this is on very, very low energy. Once we have had a little bit of an investigation around this, sort of powder needs to be removed with a high energy ultrasonic and a bit of irrigation. But I'm pretty convinced that the DB is where I initially found it. So if I feel if I sort of negotiate any further down there, I think that's going to be perforation town. So we can see here that the MB2 orifice is pretty obvious. And again, what I want to do is I just want to remove that palatal shelf, get a bit more straight line access for this MB2, because it is quite closed up. We can see here that there's an orifice, and you need as much straight line access as possible, because if you don't remove that dentin shelf, if you have that kind of overhang of dentin or enamel or the restoration that you've placed on it, it's going to be really, really difficult for your hand files to reach all the way to length. So in the first instance, I'm going to try and negotiate the MB2 with a size 10 K file. Again, it's the same protocol. We're going to just do that kind of gentle watch winding. I'm not going to ram this hand file down because I don't want to snap the file. I don't want to cause any ledging, and I just want the hand file to reach nicely to length or to the joint. And notice there's a bit of resistance there. And again, I'm going to try and work out if the two canals join. And out the corner of my eye, when I was negotiating down the MB2, I felt like that I could see the hand file in the MB1 as I was negotiating in the MB2. However, when we have a quick look, I obviously can't see that. So the furthest that I've got is at 17 millimeters in the MB2 so far. So I'm just going to open up the canal, the MB2 canal orifice again with our high diameter files. It's really, really simple. So when you're doing this yourself and you feel like you're not getting to length, always open up the coronal to mid-thirds with high diameter files, but don't go too far. And in this case, I'm using a size 15 and a size 20. I'm slightly worried about using a size 25 to open this up. A lot of the times with the MB2, I don't like to shape it up to a size 25. And then I'm just going to use that method of placing a GP cone in the MB1, and then I'm going to use a hand file in the MB2 to see if they join, because if it does join, the MB2 will catch and mark the GP cone. But when we look at the GP cone here, there's no mark at all. So I am pretty confident that the MB2 has its own canal orifice. So we're going to hook this up to the apex locator, and as I sort of negotiate this down, I feel like there's not a lot of resistance here, and I always feel like that's another kind of vote for the two canals not joining, because if there's a join, of course, it's difficult for the hand file to reach past this join, and then straight away we get our 0 reading. We're going to push it through on the MB2 through to the paper tissue, then we push it back, and then we're going to just adjust the stopper, and then great. We can see that the working length, the MB2, is 19 millimeters. And in this case, I don't want to go straight for my glide path file at 0. So I'm going to use a size 10 K file just to open up the MB2. I've come really, really far with this. The worst thing I want to do here is block or ledge this canal. So we're going to use a size 10. And I feel like the previous glide path file has done a lot of work, and so I'm going to replace it with a brand new one. Don't be scared to replace your rotary files. Again, again, it'd be the worst thing to happen. You've spent all this time shaping the canals, and then you snap it on the final canal orifice. And I noticed that this glide path file goes really nice to length, and then what I do is I shape it to a size 20 and also a size 25, mainly because I feel like it's going really, really nice and easy to length. We're then ready for our cone fit radiograph. Of course, we need to do a cone fit radiograph to see that we've shaped it to length. The MB1, the MB2 and the DB cones all go really, really nicely to length. However, when we do our cone fit of the palatal, what you notice is that as I push this palatal cone to length, and I've obviously crimped the GP cone, it pushes past that crimp point, indicating that the apical diameter of the GP cone doesn't match the apical diameter of the palatal canal. So we know that the GP cone is a size 25. So what I am going to do is we could see here with the measurements is that the GP cone measures 0.5 millimeters too far. So I'm just going to use my GP cone cutter here. So I'm going to cut this size 25 GP cone to 30. And then going to measure the newly cut GP cone to size 21, which is 0.5 millimeters from the 0 reading. I'm going to re-crimp it at that point. And then when I place this GP cone to length, as I sort of advance this GP cone into the palatal canal, I feel that this now reaches the correct the point. And when we have a little feel of it, we can get a little bit of snugness there at the apical diameter, and then we snip the cone off, and then we're going to take an X-ray. And while the X-ray is developing, I'm going to clean away my tray table because I'm ready to obturate. So I'm going to, this tray table's too dirty. We're going to obviously remove all the dirty instruments, give a bit of a clean, get my disinfection ring out. I'm going to place bleach in MB1, MB2, DB and Palatal wells. Once we've placed the bleach, I'm obviously going to use EDTA at some point. That's going to be in another well. And then we're going to use isopropyl alcohol. And this is to prepare the cones ready for our obturation. And then we get our instruments out, ready for the obturation. We're going to use our ultrasonic activator, and then we're going to use our heated plugger. And because we're using a bioceramic in this case, I'm not going to use my backfill unit. And then finally, what I'm going to do is I'm going to measure 2 of the glide path files to about maybe 1 or 2 millimeters away from the working length. And these are going to be then placed into my disinfectant ring, and these are going to be used eventually to introduce the bioceramic into the full length of the canal. And then obviously the nurse comes back. She shows me this cone fit radiograph and it looks absolutely fantastic. When we look at this X-ray, I'm convinced that the DB canal, despite the orifice being in an unusual position, is the DB canal. And then obviously we can see here that the 2 MB canals are within the acceptable range of the radiographic apex. Once we're happy with the cone fit radiograph, and then I'm going to place, I'm going to remove the GP cones and I'm going to place these into the disinfection ring. Remember, the GP cones are not sterile, so obviously they're just sloshing around in a GP box, so they need to be disinfected with sodium hypochlorite. But again, of course, when we come to place these cones, the sodium hypochlorite needs to be washed off. So before we place these, we're going to dip them into isopropyl alcohol. And then a lot of the MB1, MB2 and the DB, they kind of have a similar working length. So I'm going to use the glide path file, the same glide path file for all those 3, but the palatal is a bit longer, so I'm going to use a different glide path file for that. It's all about efficiency, essentially. And then we're going to do our final irrigation protocol. In this case, I'm going to use 5% sodium hypochlorite. That's going to be activated, really, really important to activate, and I do that until it kind of runs clear. Once it's activated, and this can take quite a significant amount of time, especially if there's 4 canals. Once it's activated and we've done quite a few cycles of this with sodium hypochlorite, and it starts to run clearish. We're then ready for our 17% EDTA. The 17% EDTA removes the smear layer, so that's when you're using our rotary files, it's creating a smear layer within the inside of the canal orifice, so that's going to be blocking all the tubules. Of course, the 17% EDTA also needs to be activated, so we're going to do that in a couple of cycles until the EDTA is clear. We're then going to use our final rinse of 5% sodium hypochlorite. And what you'll notice is you'll use the sodium hypochlorite first, that will run clear. You'll then use the EDTA, and then you'll go back in with the sodium hypochlorite. And because the smear layer has been removed, it'll start to not run clear again. So it's very satisfying that you know you're cleaning the canal orifices really nicely. So once we finish the irrigation protocol, we're ready to dry the canals with our paper points. And with hindsight, I made a slight mistake here, is because I'm not really taking note of how far I'm pushing these paper cones down. So obviously we dry some of the canals, and when I place a paper cone into the MB, what I feel like here is I'm pushing it too far, and it's gone through the apex, and I've caused a little bit of bleeding here. And then of course I place a paper cone in the MB to see if I can stop this bleeding, and also the MB2. But again, it's a significant amount of bleeding, that. And also at the same time, when I place the paper cone in the DB, the patient jumps ever so slightly, indicating that they are not numb. So given the fact that the patient's not numb, and also we've got a bit of bleeding, what I do is I just change tack, I numb the patient up again, and then I re-irrigate. You know, a lot of people have mentioned to me that sometimes if it bleeds and then I get it stop bleeding and then I obturate there, we're worried about the residue of the blood on the inside of the canal. Does that affect you know, the sealer, sort of, you know, the sealing of the canal space? So I go back with my irrigation protocol, I give it a bit of a clean out, and I go back in with the paper points. I'm very mindful now of how far I'm pushing them in, and I've noticed now the canals are all nice and clean. So we're now ready to do our obturation. I am going to get my cone, I'm going to dip it into isopropyl alcohol, and I'm going to just dry the paper, the GP cone here, get rid of all the sort of residue, and then I'm going to place that to one side, and I'm going to place my glide path file again into the isopropyl alcohol, make sure that's all nice and dry, and then I am ready to place the sealer. I am not going to be shy about this palatal canal. I know it's really, really wide, so I'm going to make sure that I fill this palatal canal from top to bottom, from, you know, mid to coronal. Make sure it's all nice and filled, and I'm going to use my glide path file here just to introduce the bioceramic into the full length of the canal, and then I'm going to get my prepared GP cone, the one that's been sort of cleaned with isopropyl alcohol, and I'm going to push it very, very gently down to length. Make sure that we get that nice, really deep 3D fill. We're then going to use my heated plugger just to remove the excess. I don't cut the excess off too far down, because I want enough for us to sort of push down into the canal orifice, and also once we sort of push the GP cone quite far down, that's going to make sure the bioceramic is going to be pushed into all the little nooks and crannies. And when we look at our post-op radiograph, it looks amazing. I'm absolutely over the moon with this, really, really thrilled. It's all to nicely to length. We've got 4 obvious canals there, and it looks fantastic. And overall, that's the case. I hope you really liked it. If you've got any criticisms, really, really important, you've got any criticisms, you would have done something different, please comment in the section below. If you know, you haven't subscribed, please subscribe, and I'll see you in the next video next week. Bye bye.